who will tell us all the numbers behind our complications.
Thank you very much. I have some disclosures here. Many companies who obviously have an interest in myopia and its treatment, but my travel here to this meeting was paid for by myself. I couldn't say no to Ramin or indeed Caroline. Much of the work I'm going to talk about today has already been published, so if you go to my website or grab that QR code, which I'll show again at the end, most of these data are available to you. So a rhetorical question is, why myopia, why now? When I was studying, we regarded myopia as something of a benign refractive condition, but our perceptions have changed for a number of reasons. First of all, we have an increased prevalence around the world. We now have the ability to do something about it, and what I'm going to talk about today, which was we have a better understanding of the role myopia plays in ocular disease and indeed visual impairment. So my colleague Noel Brennan and I published this paper a few years ago, and in it we took data from 5 large epidemiological studies across 3 continents. This represents data, I believe, on 21,000 patients. And these papers all looked at the prevalence of myopic maculopathy as a function of the level of myopia. And you can see perhaps the expected exponential increase with increase in levels of myopia. Now, when we replotted those data on a logarithmic scale, we were surprised to see how similar the slopes of the best fit lines were. And the average slope of those lines is 1.67. So what we can say is that each diopter of myopia increases the risk or increases the prevalence of myopic maculopathy by 67%. Turning that on its head, we can say that each diopter less, or each diopter we could prevent, would reduce the prevalence by 40%. One important thing to remember, of course, is that's only half the story, because when you look at some of these data, you see that around half of the patients have less than 5 diopters of myopia. So I would argue that we need to think about myopic maculopathy as a disease of myopia and not just a disease of high myopia. Now, we extended this work to other conditions. I'll focus just on retinal detachment. And you can see here data from a range of studies, including a very old paper from Switzerland on lifetime incidence of retinal detachment, all show on average a 30% increase in the incidence of retinal detachment for each additional diopter of myopia. Now, in that same paper, we accessed some beautiful work from Caroline and her colleagues, where they presented data on over 15,000 patients in whom they had both refractive error data and best corrected visual acuity data. And we replotted those data. This is them in their native Dutch form. But we replotted them looking at the odds of visual impairment as a function of myopia level for a range of different ages. And you can see the relationship is fairly impressive, and you can come up with the equation at the top, which tells us that for every diopter of myopia, there is an increased risk of visual impairment, and this is uncorrectable visual impairment, of 30%. So again, slowing myopia or preventing a diopter of myopia should reduce visual impairment by a very meaningful amount. Now, we've recently extended that work to look at the role, again, that myopia plays in uncorrectable visual impairment, focusing just on the United States. And for the projected prevalence in the middle of the century, you can see that myopia is responsible for over 1/3 of uncorrectable visual impairment. Now let's turn our attention to this part of the world, the European Union. Of course, it's to my eternal chagrin that United Kingdom is no longer part of the European Union, and for that reason I got to spend an hour of my life that I will never get back at Schiphol Airport, standing in line. But let's look at the population of the European Union now and looking forward to the middle of the century. There's not going to be much change in the overall population, but there will be an aging with a lot of population growth in the over 60s. Let's assume for the moment that the prevalence of myopia, based on this paper, will be 56% in Europe. And we can come up with some model data that show that this will predict around about 32 million patients who are visually impaired. And ignore that 47%, but you'll see that the myopes are overrepresented amongst the visual impaired population. Now, if we look at the age distribution and look at the proportion of visual impairment attributable to myopia, you see that myopia plays a much greater role in the working age population because, as we've heard throughout this meeting, the complications of myopia leading to visual impairment occur much earlier than other things such as age-related macular degeneration. We can take a broader look at the data and look at a range of prevalence values. I've just highlighted the ones we've looked at, but even at low values of prevalence of myopia, it's playing an important role in visual impairment. And slowing myopia or moving the refractive distribution by a diopter can have a substantial benefit to our patients. Now, there's limitations to these data. Much of the patients look like the lady on my right, and there's some extrapolations and some assumptions underlying it. But I think we have to agree that myopia is a major contributor to global uncorrectable visual impairment, and certainly the American Academy of Ophthalmology Task Force has focused on this. How do we address this? Well, we have to attack myopia from the beginning and to the end, and just a couple of things where we can make a difference. Obviously, preventing myopia, delaying its onset, and then administering good treatment so that we don't just wait until we're managing the disease at the end. I've been trying to come up with a useful analogy for myopia control. The best one I can come up with is sunscreen. I couldn't find any in the shops in Amsterdam, but if you go to the Mediterranean in August, there's obviously short-term and long-term benefits that may be a good corollary for myopia control. So I thank you once again for the invitation to be here, and enjoy the rest of your meeting and safe travels home.
Thank you very much, Mark, for this very interesting presentation. We have a few questions for you. So already in the audience, there's a question for you, Joe. I read it. So when you see myopic maculopathy in eyes with lower refractive error, do you check the corneal curvature? So basically, I suppose many are surprised that you have maculopathy in low refractive.
Well, I don't see patients, and I'm certainly not a retina expert, so I'd refer that to anybody from the panel who wants to comment.
So from the panel, Caroline, yourself.
Yeah, so the changes that you see in the retina with the lower refractive errors are not severe, but yes, you do see changes. And it's, yeah, we look at axial length, so even the axial length of 24 can lead to changes in the macula over time.
Just, you said me once that it's good to be low myop. That's good to be -2, -3. It protects from many diseases. So could you defend your point of view?
According to population-based studies.
Your mic's not on there, Joost.
Can we have the mic?
According to
here he
population-based
goes.
studies, myopia is partially protective against age-related macular degeneration, against diabetic retinopathy, against angle closure glaucoma, and is a perfect correction for presbyopia if it's not too strong. From my clinical point of view, the clinical problem is high myopia. Also, since moderate myopia may not be a major risk factor for open-angle glaucoma. The high myopia is a problem. And looking at your graphs, they were semi-logarithmic, and if one does a de-logarithmic correction, then one may see no longer a linear correlation between myopic refractive error and the prevalence of myopic macular degeneration, but a curvilinear markedly increasing beyond a value of -5 or -8 diopters. So that at the bottom line, for me as a hyperopic, -2 would be wonderful.
Can you speak on the association between myopia and intelligence?
No,
I
it's
was just
between
joking.
myopia and level of education, not intelligence.
It's not a causality, probably a correlation, let's say.
D'accord.
I don't know. So I like very much your sunscreen, just to finish example, because we always have this challenge of saying to myopic that they should be careful, there should be some stuff, but at the same time we don't want them to feel like they have a disease, they should stay home because they have a severe disease. So I think that's a very good.
Yeah.
Caroline, last words for
Yeah, no, I mean, your message is very important. So how do we use your message to get to the public and maybe even more importantly to the politics and try to change what's happening at schools?
Well, living in the US, I've learned to stay out of politics. It's an ugly place. But I think we need to, as I showed in my sort of 10 points on the continuum of care, we need to talk about education. We need to talk about prevention and lifestyle. I think much of the lower incidence or lower prevalence of myopia we see in Northern Europe is because of a healthy outdoor lifestyle that perhaps we're not seeing elsewhere in the world. The screens aren't evil. You know, iPhones don't come from the devil, but they do prevent children from heading outside. And we know the one thing we can do from a preventive point of view for myopia is getting people outside. In terms of funding for myopia control methods, there's a danger that myopia will just become added to the long list of examples of health disparities, because the rich people will get treated and the poor people will not. So I think we need to partner with industry and government to really address that issue.
Mm-hmm.
Thank you very much, Mark.
Yes.
Caroline, the conclusion. Thank you.
So thank you very much. So this has been a wonderful session. I would like to thank the speakers for wonderful talks. And